Good afternoon, everyone, and welcome. Thank you so much for joining us. My name is Experiential, and I'm a research fellow at the Matilda Centre for Research in Mental Health and Substance Use. And I'm also the project coordinator for Cracks in the Ice online toolkit. And it's my great pleasure to welcome you to today's webinar. Before we begin our webinar, I'd just like to start by acknowledging the traditional owners of the land. I'm coming to you from the land of the Gadigal people of the Eora Nation. And I'd like to pay my respects to their traditional owners, past and present. I'd also like to acknowledge the land upon which you are all on today and pay my respects to their elders, past and present as well. So before we begin, for those of you who aren't familiar, today is a webinar in a series of webinars that we run as part of the Cracks in the Ice toolkit. And as participants, you are in listen-only mode, and that means that we can't actually see or hear you. However, you will notice that you have a Q&A button on the dashboard, and this is where you can type in questions that you have during the webinar and send them through to us. And then we'll have a question and answer section at the end of our webinar. I'd also like to let you know that we are recording today's session, and we'll be making the recording available to you through the Cracks in the Ice website. And so you'll receive a Zoom link once that is available. So it's now my great pleasure to introduce today's speaker, Dr. Karen Drysdale. Dr. Karen is a senior research fellow at the Centre for Social Research in Health at the University of New South Wales. She conducts research at the intersection of social inquiry and public health, particularly in the experiences and expressions of health and wellbeing among marginalised communities. Through her disciplinary training, Dr. Drysdale endeavours to bring a critical cultural lens to everyday lived experiences as they pertain to public health concerns. Dr. Drysdale is particularly interested in community engaged processes for working with affected communities, with an emphasis on accessible health research translation and dissemination. So thank you so much for joining us today, Dr. Drysdale. We're really looking forward to the session. I'm going to hand over to you now to make the presentation.
Thank you. I just want to acknowledge that I'm coming from Gadigal country, gorgeous piece of country by the Colloquially River, or the so-called Cooks River, and the sun is just starting to come out. I can see through my window, which gives me a greater and renewed appreciation for this beautiful country that has been so lovingly looked after by our First Nations people. So I'm just going to share my screen. So just forgive me for the odd moment of technological incompetence until I get it up and running. Okay, so I'm going to start with just talking briefly about chemsex. So the term chemsex itself gained increasing traction over the first course of the first 2 decades of the 21st century, when it was shifted predominantly from a vernacular use among gay, bisexual and other men who have sex with men, engaged in the London sex-based social cultures. Its later adoption is probably something that we're a bit more familiar with in public health and clinical practice. That is that chemsex is used to denote a set of common health-related conditions of considerable concern. So when we think about chemsex, we're sort of thinking about the intentional and simultaneous use of drugs to facilitate, enhance, and prolong sex with an identifiable pattern of settings, relations, and practices that are commonly ascribed to gay male culture. So attention to psychoactive substance use among this population has been subject to increasing global concern regarding this use of this combination of sex and drugs. And, I just want to sort of preface this by saying that, in reality, all manner of combinations of sex and drugs, including alcohol, could be captured under this term chemsex. But chemsex has increasingly come to refer to a particular trinity of illicit substances. That's crystal methamphetamine, GHB or GBL, and methadone. Now, that we don't actually see a lot of methadone, if any, in Australia. But today I'm going to concentrate on crystal meth or methamphetamine. So that's methamphetamine in its crystallized form. And I'm just going to refer to it as crystal hereafter. So chemsex is now defined as a phenomenon that is both derived from and I would also say increasingly representative of a particular cohort of gay men. So consolidated in this way, chemsex has now become a politically salient category that's capable of spurring policy and programmatic responses. And that's great, right? Something to name and to label, and therefore to attach funding to, and to be able to do interventions under this name. That's really great. However, this is a sort of a consolidation that I'm increasingly concerned with, that where it's, I guess, associated almost by default with risk. And it's at this point, the risk that's associated with chemsex, that I kind of want to challenge here today. So you would probably all know, probably way better than me, because I'm not an epidemiologist or anything, about the prevalence and the possibility of the way that crystal has become pervasive among certain populations in Australia. So crystal is a relatively accessible and affordable stimulant drug. We have known negative health outcomes from crystal use, such as drug dependency, physical and mental health disorders, and these harms have contributed to substantial social and economic costs. But while some of the harms of crystal can affect all people who use it, there may be some additional risks for people who combine the use of this drug with sex. So crystal enhanced sexual practices among gay and bisexual men include things like condomless anal intercourse, group sex, vigorous sex, sex for extended periods, and intravenous injecting. And all of these things have been associated with the increased transmission of blood-borne viruses and sexually transmissible infections. Now, compared with the broader Australian population, gay and bisexual men report a higher prevalence of crystal meth use, and it's actually been found to be the most commonly injected illicit substance among this population. HIV-POS men are more likely to report crystal use compared with HIV-negative or untested men. So what we're seeing with this very rough sketch is a bit of a picture of crystal use among potentially a group of sexually adventurous men, and also those that may have related or faced stigma and discrimination because of their HIV status or because of their injecting use status at some point in their lives. So it's amid this concern, right, in these overlapping fields of HIV prevention and LGBTIQ community health, but also among, I guess, a bit of a moral panic that we've seen among gay and mainstream media outlets. So it's in this context that this project was born, the Crystal Pleasures and Sex Between Men. So the Crystal Pleasures and Sex Between Men project was the outcome of an NHMRC grant with researchers from the Centre for Social Research and Health, the Australian Research Centre in Sex, Health and Society, or better known as ARCHES at La Trobe. And we partnered with ACON Thorn Harbour Health, at the time they were still known as VAC, and Samish. And we originally concentrated the study in Sydney, Melbourne and Adelaide. Then the WA Department of Health came to us and said, this looks like a great project, can we have a look at Perth too, please? And so we entered into an additional funding relationship with Perth and the Western Australian AIDS Council. So the QR code on the screen will take you actually to the project page where you can find all the resources that I'm going to mention throughout this talk, which is very exciting because I got to actually generate my own QR code for the first time. So the project aims were to examine gay men's patterns of crystal use and sex practices, to document how they protect themselves in situations where there's a combination of drug use and sex, and also to investigate how drug use and sex contribute to the social relationships and identities for gay men. And it's this last aim that I'm probably going to spend most of my attention on today. So data was collected via individual semi-structured in-depth interviews conducted with 88 gay and bisexual men residing in Adelaide, Perth, Melbourne and Sydney. Now, the cities were chosen specifically because Sydney and Melbourne are obviously the two largest cities in Australia with high concentrations of gay and bisexual men. So quite similar to London, I guess, where we can sort of see the rise of chemsex. But Adelaide and Perth were also really useful to explore because they're less populous states. The gay and bisexual male populations tend to be smaller, but they're also much more geographically dispersed. And I think this has really important implications for that social aspect that that we'll be talking about today. Interviews were generally an hour long. We discussed experiences of initiation into drug use, patterns of crystal use, the practical and relational dynamics of risk related to sex and drugs, and how these dynamics were negotiated within these diverse networks. And we also asked them about their perspectives on existing health promotion and harm reduction services for gay and bisexual men who use crystal. In addition, we also ran a series of in-depth semi-structured telephone interviews with key informants. I'm just going to refer to them as KIs as I go forth, working in AOD, health policy, sexual health, harm reduction, and bloodborne virus prevention fields. So we identified KIs through consultations with the project partner organisations, and we wanted to get a range of perspectives from management to frontline service delivery from each of these relevant sectors. A total of 35 key informants were interviewed, and that was approximately 45 minutes to an hour. So in this webinar, what I'm going to do is go through a number of articles that we produced from this project, and I want to link them to the key concepts that I'll be talking about today so that we can better understand this phenomenon. But at the outset, we were really clear that we wanted to approach crystal use among gay and bisexual men as a cultural phenomenon rather than as a series of risk-enhancing practices. I think that's a very important distinction to understand. This is a culture, chemsex is a culture that's being developed rather than what we might see from a public health perspective where, where men are engaging in really high-risk behaviours. And what I wanted to think about was what connects the use of crystal among this quite disparate group of people? What shared meanings cohere around crystal use, and how do these meanings influence those practices and behaviours, and what that might actually mean for service delivery as well. So to be clear, none of the work that I'm going to describe today is wholly mine, and all of it is a collaboration of research and partnership effort. And we have monthly meetings for this project with all of our partners. That continued for over 3 years, so well beyond the life of the actual funding of this project. And so it is with immense gratitude to my amazing colleagues that I'm able to speak to you on their behalf today. The other thing I just want to mention is I'm not going to go into great detail with individual quotes or excerpts from our research participants, because that will actually be in each of the articles that I'll describe, and they're available on the site if you follow that QR code earlier. So I'm going to give quite a high-level account of our findings, but I want to spend more time on connecting the dots between them. So on to the first one. This is a paper that was published at the outset of our project. So over the last 2 decades, there has been a substantial growth in methamphetamine-related research in high-income countries such as Australia, the UK, and USA. And this is a really important body of work of mostly quantitative research that has made a significant contribution to our understanding by outlining the range of sex and drug use practices that are associated with poor health outcomes. And so our analysis in this article draws partly on a systematic review of the methamphetamine literature that the team members conducted as part of the NHMRC grant submission. The review found there was an overwhelming majority of published articles that derive from the disciplines of epidemiology, psychology, and public health, and that this research mostly uses quantitative methods, particularly cross-sectional surveys, as the preferred research method. So we found that within this public health research, crystal was often portrayed as something that's inherently risky with long-term negative health outcomes. And in the processes, we found that researchers and the authors of this substantial body of work tended to reify methamphetamine as a stable, singular, and definitive object with well-established harms. However, and this is really crucial, right? The precise nature of the association between crystal use and bloodborne virus and STI transmission, especially HIV, remains unclear. So it's not largely acknowledged that not all patterns of crystal use are problematic or result in poor health outcomes. And there's often a correlation rather than a causality in relation to the use of crystal and those negative health outcomes that I've just mentioned. So this lack of clarity has opened the way for certain assumptions to take hold. And indeed, biomedically informed behavioural studies often slip between correlation and causality and directionality between drug use and sexual behaviour. And this is something that we suggest is part of an overall tendency towards problem inflation in research on crystal. So specifically in some public health research, assumptions about the relationship between risky sexual behaviour and the acquisition of bloodborne viruses and STIs frame gay and bisexual men's sexual activity as problematic. So this sets up a bit of an inescapable dualism that we have to contend with. So we've either got the consequence of consuming what is characterised as a highly potent and addictive substance, or this is the practice of risk-inclined and reckless individuals. So the first is that methamphetamine has specific pharmaceutical properties that can lead to sexual disinhibition, risky sexual behaviours and poor health outcomes. But the second explanation is that methamphetamine attracts men who are already inclined towards these highly sexualized interactions with the drug and risk-taking. And so that these men are already likely to engage in these practices with or without using drugs. So these slippages in causation are one part of establishing this seemingly, or perpetuating this sort of seemingly wide view about the methamphetamine and sexual risk-taking relationship, where the responsibility of sexual risk behaviour is seen to lie in either the wicked properties of the methamphetamine drug itself or the risky and undisciplined character of the men who are taking it. And to me and to our team, and maybe to all of you, that these positions are problematic, right? They position gay men who use methamphetamine for sex as either victims of methamphetamine, who lack rationality and they lack self-management, and who are desperately in need of help, or as somehow deficient or deviant in their desires to seek risky drug and sex practices simultaneously. And so both views tend to individualise methamphetamine use and removing it from the social, historical and political contexts in which drug use always takes place. And so this is one of the first concepts I want to discuss with you today, this issue of sex-based sociality. So when we talk about sex-based sociality, we're talking about the ways in which people use drugs and the drugs that they choose to take, the settings in which these drugs are used, the other people involved in drug use, that these have important social, historical and political dimensions. Relationships, identities and cultural and subcultural meanings get attached to drug use. Historical moments and geographical spaces all contribute to the making of particular forms of drug use among specific populations at different times. They also influence the perceived effects of particular forms of drug use. So going back to that notion of methamphetamine being this sort of stable, singular property is actually just not borne by the evidence that we have, that people experience the effects of methamphetamine in different ways depending on the set and settings. So here we can take gay community as a kind of cultural and collective product for gay and bisexual men because it creates and supports specific kinds of involvements, participation, relations and belongings. There's also cultural meanings attached to practices that are specific to or common within these communities, including drug use. So all of this constitutes much of the sociality that is present in gay community life. So that is, when I say sociality, I'm talking about the sort of development of social links where various experiences and varieties of relationships evolve over time and community members are invited to participate, practice that type of relationality. So gay men's unique relationality is an important constituent of the sociality of gay community. But there's one feature which is quite unique to gay community that other social communities may lack, and that's sexuality. So sexuality in its identities, its practices, its relationships and its meanings provide one of the key ways in which sociality is built for gay men. And so sex underpins the relationality that exists between different groups of men within this notion of gay community. And this can be witnessed in gay clubs, dance and circuit parties, sex on premises venues and private parties, where among some men, group sex and collective drug use is quite a common way of socialising. So sexual activity can shape drug-using practices in gay communities through the particular meanings that gay men might attach to those drugs. And the use of drugs in those communities can facilitate relationships of sex that in turn build stronger engagements with aspects of gay community through, friendship and social and sexual networks. So I want to hold on to this idea because this is something that we're going to see across the suite of work that we've done in this project. So the second paper that I just want to now draw to your attention is this paper, Destabilizing the Problem of Chemsex. While not all gay and bisexual men who use psychoactive substances report problematic use, those that do often become representative of chemsex practices more generally, right? So when we're thinking about some of the moral panics that we've seen in press, in mainstream press, when we look at that Vice documentary on chemsex, for example, what we can see is that the harms that these particular individuals might experience in relationship to their sex and drug practices, they kind of become attributable to all men who are using drugs for sex. But as I outlined earlier, the ways in which sex and drug taking practices have been framed contributes to this really narrow set of understandings defined by the circumstances and the behaviours presumed of drug-enhanced sexual activity. So there's substantial literature on this now, and our analysis suggests that this kind of definition or political stability of the term or consolidation of the term chemsex relies on three intersecting elements: that it's facilitated by online technologies, that drugs are used intentionally for sexual purposes and only sexual purposes, and that chemsex practices are necessarily risk-inducing. So this is not to say that all the literature on chemsex necessarily combines all of these elements or isolates any of them as chemsex. But what we're finding is over time that we're seeing these elements become intertwined, and they tend to operate as a rhetorical shorthand for chemsex. So the first element is around the transformation of hookup culture specific to gay male sex-based social life. And you can see the growth of apps and the availability of psychoactive substances connected to those apps in the literature, with the widespread use of geolocation apps among gay and bisexual men. So Grindr as an example. So we can think about chemsex as being embedded in this type of hookup culture facilitated by technology. But our findings actually suggested that there are a wide range of practices among gay and bisexual men who use crystal meth in combination with sex in Australia. So first, there's not a universal expectation among participants in our study that casual hookups would require crystal use as part of participation in sex. But what we found is that men's responses to offers of crystal were often considered within the anticipation of casual sex. So approaching the possibility of sex on crystal was characterised by men in the study as a curiosity or an adventure, and that these men's decisions to engage in crystal use was inseparable from their openness to sexual exploration, or the desire to take a break from the banality of stresses of ordinary life, or to even disrupt the perceived monotony of vanilla sex in their sex lives. So this suggests that the decision to use crystal for our participants at least, was both reflective on and constitutive of men's experiential and exploratory sexual subjectivity. And this is regardless of whether the offer of drugs was actually anticipated. So drug use, at least for the first time in using crystal, can sometimes be considered incidental to sex. That is that crystal use was relationally and context specific to the moment. Now, the second element is that substance use is sought for its instrumental capacity as facilitating, prolonging or enhancing sex. And, crystal has been identified in all of the chemsex literature as a chemsex drug because of its perceived potential to facilitate the type of disinhibition, arousal and adventurism. And it's often distinguished from earlier party use drugs like MDMA, cannabis, things like that. But in our findings, again, not all experiences of crystal use began or remained tethered to sex. So questions in the interview focused on men's experiences of combining crystal with sex, but participants often offered accounts of use of crystal for non-sexual purposes. So their experiences of crystal for socializing encounters, for example, actually counters that view that crystal is intentionally only used by gay men for sexual purposes. We also found that people who reported using crystal only for sex also often that people who reportedly use crystal for sex now often referred to prior uses of the drug in wholly social engagements, underscoring how the process of socialization comprises the context of drug use. So here, crystal was reported to have been gradually incorporated into participants' established patterns of drug use. And our findings provided evidence that the consumption of crystal can form part of social engagement for gay and bisexual men, at times variously connected to sexual activity, but sometimes beyond purely sexual ends. And just the third element is the contention that chemsex practices are seen as risky, as they are predominantly described as involving condomless anal sex, intercourse with multiple partners, group sex, vigorous sex, and sex for a long duration, which, to me all sounds pretty good, actually. And of particular concern in the public health literature is the connection of crystal methamphetamine use and HIV transmission. And, in the early days of chemsex, as a moral panic, we saw warnings of a potential double epidemic where the escalated use of chemsex drugs was seen to be connected with increasing HIV transmission rates. And so that there's this assumption that chemsex is inherently risky, right? So again, while men in our study commonly reported all of those things, condomless anal intercourse, group sex, vigorous sex, etc., what we found is paying attention to the wider context in which these sexual practices were associated actually destabilizes that automatic association with risk. And so the pleasures that are associated with these combinations of sex and drugs were often reported to be indistinguishable from other aspects of social and sex engagement. So we're not talking about a stable culture of chemsex that has somehow attached itself to a particular group of men, and that the particular group of men will just continue with these risk-inducing behaviours. So consequently, the stability or shifts in the settings of crystal use and sex have in turn sort of shaped those practices and those risk reduction practices. So considerable knowledge and experience of different modes of administration, for example, are evident in these men's combinations of sex and drugs. And the modes of administration, by which I mean, injecting, snorting, though, and I know that sounds crazy, but there have been reports of people snorting crystal methamphetamine, which I can just imagine how painful that would be. But smoking and also shelving, so sticking it up your bum. All of these different ways of using crystal actually affects the meaning that they attach to it and the way that they understand that connection between sex and drugs. So rather than approaching chemsex as a singular object or a narrow set of practices, we wanted to destabilize the term so that a greater diversity and contingency of practice can be captured. So this is a critical approach to understanding chemsex that retains its discursive and practical value. And I mentioned earlier, there's some real value in the consolidation of chemsex in public health because it allows you to apply for funding, it allows you to frame interventions, it allows you to even recruit under that umbrella term. But it moves beyond these stabilized definitions. So we want to argue for a much more nuanced approach to chemsex that does not a priori include consideration of all the other experiences that go hand in hand with the combination of sex and drugs. And so there's a danger here that if we continue to frame chemsex as a necessarily risk-inducing object of concern, then gay and bisexual men may not connect with those educational or promotional interventions because they don't see what they're doing as chemsex, right? Especially given that moral panic around it. So they're just using crystal, having sex. They're not engaging in chemsex. So if we can recognize and harness this much more expansive use, then we can probably amplify the effectiveness of community-led and culturally specific support services, but also acknowledge the role of pharmacologies, lay expertise, but also the value of experiential knowledge in developing harm reduction practices in these various settings. So this is where we land with this analysis. If chemsex is only conceived of in terms of its problem, then it necessarily confines the approach to a set of health-related conditions, and it really limits the analyses that are made possible within the parameters of this problematization, and therefore inhibits the response available to men who use crystal for sex. So what we're trying to do here is to destabilize the problem of chemsex. Okay, so next one, taking a little bit of a shift here. This article derived from our interviews with key informants specifically. So closely associated with the problematization of chemsex risk is the perceived and actual impacts of stigma on this population of gay and bisexual men. Numerous studies have demonstrated an association between the experience or expectation of stigma and poorer health outcomes. I'm sure this is not news to you. Stigma is here defined as the co-occurrence of labelling, stereotyping, separation, status loss, and discrimination where power is exercised differentially. So we looked at stigma as it was perceived across a numerous number of domains. So here at the individual level, our findings showed that it's really important for individuals, services, and policymakers to understand why many gay and bisexual men are using crystal. So some key informants offered the view that crystal is used by gay men to reduce the debilitating effects of internalized stigma related to being gay or bisexual. So this is a kind of internalized homophobia. And this also connects with people's experiences of living with HIV, the stigma associated with a person who injects drugs, or someone who participates in particular sexual practices. You know, they're often referred to in the field as esoteric practices, which is a bit of a funny term. So studies of stigma have typically focused on stigma at that individual level, right? Because it in turn has led to the development of interventions such as resilience training for stigmatized communities or contact-based interventions with the aim of producing a higher quality interpersonal dynamic between, for example, healthcare professionals and stigmatized individuals. But stigma was equally seen by key informants to be produced and experienced within social and sexual networks specific to the particular drugs and the modes of administration among gay and bisexual men, which, as I've just sort of discussed, get attributed with different meanings in practice. So key informants often referred to a hierarchy of acceptable drug use within these networks by referring to the use of hard drugs such as crystal and GHB as somehow crossing a line in relation to the more acceptable forms of drugs within gay culture. So MDMA, for example. Some key informants thought that other gay and bisexual men could be unsupportive of men who find themselves in trouble with crystal, resulting in gay and bisexual men maybe only disclosing their use to trusted healthcare professionals. Many were fearful of the partners or the friends or the family's reactions. And also this extends to the hierarchy of acceptable routes of crystal administration believed to be held by gay and bisexual men, where injecting drug use might attract a higher level of scrutiny or disapproval among these networks. And this, adds to the stigmatization of gay and bisexual men who inject rather than smoke. And so the sanction on injecting drug use and also hepatitis C status as a proxy of injecting was said by key informants to inhibit gay and bisexual men from seeking information and help from drug treatment services. So stigma was also recognised in the operation of services and organisations. So key informants described challenges as relating to stigma, some of which related to the distinction between harm reduction and abstinence-based approaches to addressing drug use. So drug treatment and other mainstream AOD services were typically described by key informants as unattractive or even unsafe options for gay and bisexual men in relation to the disclosure of sexuality and sexual practices, HIV status, and so on. So these key informants perceived that gay and bisexual men who use crystal would only really attend these AOD services when the crystal use had developed or become problematic. So services that provided group treatment options, for example, could be seen as particularly problematic in reinforcing stigma or silencing gay and bisexual men who may not be able to connect their experiences with the group experiences, or they're fearful of sharing their experiences in fear of stigma and discrimination. Now, an alternative is community-based organisations that involve community members, and peers especially were said to be the best at engaging clients and building rapport because they themselves may have experienced that stigma and discrimination in their own experiences, right? And so they're typically able to connect with these gay and bisexual men on that level. But interestingly, key informants also described how stigma associated with crystal and injecting have reshaped some organisations as individuals chose to leave because of tensions in the organisation's approach to services or policies on crystal use. So key informants thought that while these staff departures could reduce some of the conflict within an organisation, they might also result in that organisation having less support from some segments of the community or being less able to represent some various perspectives and needs. And now finally, stigma was also perceived by way of encompassing the structural aspects of the environment related to public policy. In particular, mass media messaging on crystal use was seen by key informants to be a significant generator of stigma. Anti-drug campaigns were seen to produce the negative or deficit perceptions, and it's often prescribed through a projection of a kind of law and order perspective, where these deficit perceptions are really negative and they lack a message of hope. Now, I recall really strongly flicking through a really old copy of Lottle, Lesbians on the Loose, which is a publication for queer women. And, you know, they would have these kind of like ads against crystal use. And it almost inevitably involved someone poorly dressed by themselves in some kind of dubious context, like an alleyway, you know, just looking really haggard and unhealthy. And so, you know, there's that sort of really negative association with crystal use. And this is interesting because crystal use at that time wasn't actually really correlated with women's sexual practices at all. You know, so again, you know, really disassociated from the context in which this drug use is actually really in reality experienced. So the KIs felt that for those people who did encounter problems with their crystal use, the messages in these campaigns were kind of of limited value for gay and bisexual men who didn't connect with those characterizations of people who use drugs, and for whom the message was perceived to place responsibility on the individual to get the shit together, right? No capacity to consider the social environments in which drug use might become normalized or a part of a person's kind of wider social and sexual networks. So challenging government policy to address stigma was described by key informants as difficult and complex. And this is because their organisations are often funded by those same people who are producing those messages. It makes it really difficult for community-based organisations to straddle those positions of responding to community needs, as well as working effectively with funders. And, you know, I can't see all your faces here, but I just can imagine, yeah, like, of course, I'm sure that many people have been in the same position when you do work in this area. So this is another concept that I just wanted to introduce to you, this idea of stigma ecologies. So data was examined as relevant to these 4 levels, right? Individual, social and sexual networks, community organisations, and public policy structural levels. And so we use the HIV epidemic stage, which is in this original model here, as a background to these analyses. So this stigma ecology was developed by Borel and colleagues and as an adaptation of the original ecological systems that are proposed by a colleague of German descent, I'd imagine, and I'm not going to try and pronounce the surname. So here we've got, in addition to those 4 levels that I've just outlined, we've got this 5th level, right? HIV epidemic stage, which is important for contextualizing the risk associated with particular individual, network, community or policy actions. So here we used HIV epidemic stage as a proxy for understanding trends in the patterning of HIV and hepatitis C and drug use among gay and bisexual men in Australia, as related to those concerns around chemsex, as well as those high level debates or moral panics around the use of drugs in contemporary societies. So this social ecological model is useful to ensure that attention remains paid to all the levels that can produce stigma and importantly sustain stigma. So the key informants were navigating each of these levels in their own practice as service providers and as managers and advocates to illuminate these intersecting influences of stigma. And these data strongly suggest that effective stigma reduction interventions must address each of these levels, and they must be underpinned by that broader understanding of sex, sexuality, drug use, infection status, and sexual minorities in these much more broader social terms. So taken together, key informants emphasise that reducing stigma involves going well beyond the delivery of services in a respectful and non-judgmental way. Effective stigma reduction require engaging with power as it operates within and around these social processes that stigmatise practitioners of chemsex. And such efforts need to be informed by a culturally competent approach that is itself informed by analyses of power as they relate to all of these multiple identities and practices. Okay, so there is a power dynamic even in the most altruistic of healthcare interactions. So without this kind of nuanced, nested and multiple understanding of how best to tackle and undo stigma, we run the risk of designing programs and interventions that inadvertently generate new mechanisms that reinforce the negative effects of stigma, right? So those public health campaigns against crystal meth use might actually work to increase stigma felt or perceived within that healthcare interaction between gay and bisexual men and healthcare professionals. Okay, so the last paper I want to chat to you today about is what I've called the Priorities and Practices paper. So from challenging the rush to risk in the first article in addressing chemsex and its alternative framing of sex-based sociality, to destabilizing chemsex's inherent problematization by dismantling the assumptions that combine to give it particular meaning, and to recognizing and responding to layered stigma ecologies that impact men's self-well-being and service engagement. We're now turning to how privileging men's experiential knowledge can aid analyses of drug use and drug-enhanced sex. So given the emphasis on blood-borne viruses and STI risk in the literature, we asked our study participants how they understood their own sexual health risks in relation to crystal use for sex. So they described having mainly adopted biomedical HIV prevention strategies, by which I mean PrEP, pre-exposure prophylaxis, and treatment as prevention, or U equals U. So participants believed that these strategies were efficacious and that those who used them expressed little concern about HIV transmission. For other participants, HIV transmission or acquisition was something that they ought to be cautious about, and men negotiated a range of practices with specific partners in addition to using these biomedical strategies, such as condom use, for example, or serosorting or negotiated safety. And they often prioritise the safety and preferences of their sexual partners. And this goes back to that social sex-based sociality idea, that here the risk reduction was not often seen as an individual responsibility, but something that's negotiated ongoingly and dynamically with various people, and that these negotiations actually then shaped and changed the individual preferences for risk reduction strategies. So STIs, on one hand, were seen as really relatively easy to acquire, and some participants sort of perceived them as an inevitable consequence of drug-enhanced sex. But they were often understood as having effective treatment options, and so they were seen as minimal concern and easy to manage. And in some cases, this actually included the preemptive use of antibiotics before an anticipated potential exposure to an STI without waiting for a diagnosis. So kind of like an antibiotic preloading, I guess, of sorts. But for other people, STIs continue to be a source of embarrassment. Disclosure of STIs to potential sexual partners was associated with stigma. And there was a lot of stigma associated with the frequent presentation to healthcare services. And that was actually seen as more of a concern than actually getting an STI itself. So having to go constantly back to get, the morning after pill or PEP, for example, if they had an exposure, or preloading or going to get antibiotics every time they're at risk of having an STI. So in contrast to HIV transmission, which is seen as avoidable, and STIs, which is seen as common but manageable, hepatitis C didn't really get a look in among this group of people. There was a lot of confusion among participants about the distinction between different types of hepatitis. So when I asked people about their hepatitis status, they often reported being vaccinated against hepatitis C. And this is another interesting point. When you ask people if they share injecting drug equipment, 100% will go absolutely no. They've learnt the lessons, they've been told about the problems of sharing injecting drug use equipment, and they will not do it. Asked in another way, talk me through how you set up and how you kind of go about setting up for a chemsex party. People will say, well, I set up my sharps bin, I've got my tourniquet that I can lend to people and I inject them using my tourniquet. We might share mixing up vials. And we know that is a high risk of transmission of hepatitis C. But yet gay and bisexual men didn't really sort of connect these auxiliary injecting equipment with transmission risk. My hypothesis is this is a product of the fantastic HIV prevention education that gay and bisexual men have grown up with. But here with HIV transmission, that kind of is really restricted to the actual, the barrel and the needle, right? Where you can't think about HIV transmission through sharing a tourniquet or a mixing up vial. So this is where I think the strength of that messaging in some ways has actually drowned out the capacity for further messaging around hepatitis C risk. So we also asked participants about the perception of other risks when using crystal for sex. And overwhelmingly, men in our study were concerned about developing dependencies on either crystal or the sex that crystal facilitated, and that preventing these dependencies was way prioritized over bloodborne viruses and STIs. And participants commonly use the word addiction to describe dependence and characterize this as two different types of dependence. Now, in the harm reduction field, we don't use the word addiction often. It's quite a stigmatizing language. And so it was really striking to me that these gay and bisexual men did use the word addiction to describe these particular relationships that they have with dependency. So the first referred to becoming dependent on crystal, which was seen as highly addictive, potent and dangerous. So in particular, the intense pleasurable qualities of crystal use, but also the discomfort associated with coming down prompted this kind of repeated and extended use of the drug, its cyclical nature. And that was seen as increasing the risk of dependence. So they described the rush that crystal produced as playing a really important part of this dependence. However, and this is the flip side of this, if they have this preconceived notion or the expectation of a powerful dependent response, when they don't actually experience that themselves, then it's seen as then not risky. Oh, okay, it doesn't apply to me because I never experienced this kind of instant dependency producing quality. And so therefore they were more likely to engage further with the crystal use. The second notion of addiction described by participants related to the sexual openness, adventurism and responsiveness that became possible when they were using crystal. So the addiction to crystal enhanced sex is seen as distinct from the dependence on the drug itself. And I think this is a really important distinction to make. Sex on crystal was described as intense and euphoric, in which caution or reticence around potential partners was diminished or removed. And participants noted dependence on the type of sex that crystal enabled. And this was often measured by being unable to enjoy straight or sober sex. So connecting these two ideas around addiction is this concern about losing control. And this specifically meant not losing control during drug-enhanced sessions or when engaged in sex. And this concern about losing control extended to other aspects of daily life, such as the potential for diminished health and mental health, physical and mental health, missing work, jeopardizing relationships. So there was a balancing act that men in our project were trying to achieve here between an acceptable loss of an acceptable loss of control that allowed those pleasures of combining drugs and sex to take place, between the need to avoid developing these dependencies. Okay, so it's a bit of a balancing act between managing the sort of like the good parts of losing control with the bad parts of losing control. Okay, there are also other less common accounts around injecting that represented the practice as a means of control around crystal use. So for example, we have a quote from one of our study participants who said a preference for injecting crystal over smoking allowed participants to predict when a session would end. So smoking was seen as incremental, as having less control, where you might lose an entire weekend, to maybe when you're blasting or injecting, and then you have sort of a finite period where you're under the effects of that particular drug. So there are lots of examples in the article that I would draw your attention to, but we can see that in this short little table here, there are so many contradictions between the risk reduction practices that various men employed. And it's really hard to make sense of these contradictions. So what I want to do with these contradictions is suggest that these are developed through experimentation, and successful strategies are maintained to pursue that controlled form of crystal use. And they actually did this in quite sophisticated and sometimes unconventional ways. Also, that these risk-reducing strategies were shared. They circulated among networks of gay and bisexual men. And so they actually require a perception of other people's needs, the negotiations, the commitments that are particular to each of these settings and networks. And they draw on this knowledge and practices that are developed and shared within these networks. Importantly, these strategies actually demonstrate a lot of care for others and not just the avoidance of individual negative repercussions. And this also suggests the presence of trust. So trust was required by participants, especially when they had to rely on others to ensure that the crystal that was provided to them was of appropriate purity and strength. So for example, for those that had a strict rule that they would never buy the drug itself, they depended on other people giving it to them. You have to trust that what you're getting from your sexual partner is an okay form of drug. But also, the trust that's required in the ability for others to inject, and trust in others to avoid injecting others as well. So there's a lot of trust happening here. Now, these strategies, looking at these, they probably depart from, or at least are contradictory to, commonplace wisdom within the harm reduction field. Not taking responsibility for one's own drug supply or consuming all available drugs in one event might depart from the recommendations that we put forward as harm reduction practitioners. But interestingly here, what was assumed to be risk-inducing by public health advocates was, for these men, a method of control, and that this method of control was experienced as pleasurable. So strategies are, in effect, these collective practices that may seem unintelligible to outsiders, but they actually have an intrinsic logic and creativity of their own. So this is the last concept I guess I want to really chat to you about today, is how these consolidations of these strategies might potentially exemplify a counterpublic health embedded in this notion of sex-based sociality. So for over 30 years, research in Australia has provided clear evidence to suggest that gay and bisexual men develop care practices, right? Cultures of care, these kind of learnings that support collective forms of harm reduction and safety in these networks that are structured by sex-based sociality. We found that modes of peer engagement can take place in tandem with, or even exist in the absence of, access to formal service provision. For me, interviewing 88 gay men as a part of this particular study, especially in the cities of Adelaide and Perth, we found that there was actually not a lot of engagement with healthcare services. And so that these types of health, counter-public health strategies were actually developed without that kind of information that's provided that you might see, say, in an NSP, or you might see an LGBTIQ health organisation like ACON or VAC or Harbour Health. So by counter-public health, we mean the situated knowledges and practices that develop out of the specific structures and meanings in these marginalised settings. Counter-public health as an idea helps us to better understand how public health responses towards marginalised populations often make these normative assumptions about the subjects they address by failing to acknowledge the local practices and care practices of networks of people. So a key to improving risk reduction approaches lies in harnessing these discourses and strategies that men draw on and deploy during sex on crystal. You know, sitting around naked after a bit of a session and having a chat, having a yarn with the guy that you've just had sex with, while you might be smoking a pipe, for example, is actually a public health intervention in a way. You know, some of the strategies that gay and bisexual men have adopted might confound our public health assumptions, but they actually derive from very carefully considered and shared approaches to the generation of pleasure, the maintenance of a controlled feeling of being out of control, and that socially situated negotiation of risk. So the challenge for us as public health and community health practitioners lies in interacting with and capitalising on counter-public health embedded in sex-based sociality to sustain and nurture and protect gay and bisexual men's health in ways that work effectively for them. Okay, so finally, I just want to touch on a partnership approach. We built on a very strength-based approach that led to a very innovative form of research dissemination. This QR code will take you straight to SoundCloud, where you can actually listen to these episodes. So, you know, at the end of this project, we were thinking, right, we've got a series of guys who are probably engaging in some problematic forms of chemsex, sometimes not. Sometimes they're engaged with healthcare services. Sometimes they know about the existence of NSPs and other forms of harm reduction, but sometimes not. So we wanted to try to connect with this audience in ways that were authentic and resonant, that met people where they were, but also a way of trying to attract attention to this issue in let's be, you know, face it, it's a really crowded space, this whole public health priorities space, right? How do you make one thing heard amidst all of the things that we're grappling with? So the team felt that podcasts could probably disseminate this health promotion and harm reduction strategies through personal stories that privilege experiential knowledge. We knew that the podcasts need to be underpinned by a commitment to harm reduction. So that's obviously meeting people where they're at. We thought hard and long about it, and we essentially identified 3 key audiences that we hoped to reach. And then, of course, it was just a process of working with our partners to refine the key messages that each podcast sought to impart. We wanted to relay information and resources, but we wanted to avoid sensationalising the issue or inducing panic. And we wanted to use key community members with lived experience in each of these targeted audience groups who could speak directly to their own experiences at the same time as passing on their wisdom. So once we had our messages refined, we essentially had 3 messages per episode. We then matched each message with compelling excerpts from our transcript interviews. So the first episode conveys some of the strategies that gay and bisexual men can use to manage their crystal use. And it ends by promoting more opportunities for early intervention, conveying where these interventions might be possible, but also where peers could be effective early intervention points. The second podcast was actually targeted towards people in the community who interact or support people who are using crystal for sex. And we wanted to also think about how we can combat stigma and discrimination that exists around this issue. And importantly, we also adopted or promoted some strategies from these people who support other community members in avoiding burnout, when we suggest that they have to take some time to think about their own support needs, their own lives as well. And then finally, and I think this might be of relevance to all of you today, is we also engaged with healthcare professionals who are supporting gay and bisexual men using crystal for sex. What we did is speak to people from the harm reduction, AOD, and community health sectors, and talked about their experiences of reaching out through those siloed sectors and promoting a more collective, cooperative approach to this particular issue. So for me, one of the major strengths in these podcasts is the collaborative effort, not just in terms of the partnered organisations, but also the content of the podcasts themselves. And so in this way, we drew on the strengths of community, of health services and research to focus the attention on issues that are most relevant to each of these target audiences. So look, we hope that these podcasts will demonstrate how research findings can connect with affected communities. We hope that they will allow for a much more meaningful engagement with those people who may be concerned about their own or others' crystal use. And we hope that this will enable stakeholders to tailor and adapt material for additional or more targeted responses. That's the aim, at least, that we have. And, it's really gratifying to see these podcasts go global. We've seen evidence of them being used in workforce training. We've seen it across the world. I think the last someone pointed to me some discussion about this in Mexico, as well as Europe, Northern America, and so on. So I think there's actually some value in this type of form of engagement. So finally, acknowledgements. I'm not going to go through it all because the slides will be available later for you. QR code, again, will take you to the project page at UNSW, and there's the URL down there as well. All of the publications, all of the podcasts are all on that page for you to have a look at in your own pleasure. And I'll stop talking now because I'm actually really keen to hear from you.
Thank you so much.
Oh my God.
Yeah, I know, it's 1 o'clock already. We were all so enthralled that the
I forgot. I should have said you have to give me a heads up on the morning.
That's okay. I'm just going to sneak in one quick question, and it's just around sort of the terminology that's being used within the harm reduction for dependence. So I know that in our work we've come across resources like Language Matters and ADF's Power of Words, and it's all around sort of that person rather than focusing on their drug use. Is that similar in the harm reduction field?
Of course. I mean, as researchers, we need to, avoid stigmatizing language, right? We know those language guides, we use them all the time. And it's quite a humbling thing to be corrected by a community member where I've tried to use the most, non-stigmatizing, non-judgmental language. And they're saying to me, no, use the word addiction. This is what it relates to me. So I'm a qualitative researcher. Part of the job is to meet people where they're at, to experience their own life worlds, their own views of reality, right? Yeah. So, we have to adapt it. I would never use the word addiction without scare quotes in any kind of formal area. But if I'm talking to someone and they're using the word addiction, then I'm going to have to use it as well. Otherwise, they're going to think I'm some kind of wanker who just doesn't see reality. Yeah, that's really important. Language is so intrinsically connected to language, right? To stigma and discrimination. So
absolutely, yeah.
It is a balancing act between what we might see as really problematic language and language that actually resonates with particular affected communities.
Yeah. Excellent. Thank you so much. And I think you also answered the other question, which was just around any advice for health workers who might want to talk to people sort of about this. And I think you probably will just say, listen to the podcast.
Well, yeah. Short answer, yes. Look, I mean, the podcast, I think it's really interesting. We had practitioners from Perth and Melbourne and Sydney, all coming together. And, these podcasts are like a conversation, really. Yeah. And that's really important. So there's a promotion of the idea that people should talk to each other across these different sectors. And then the podcast itself actually did that. So it's kind of like an example of what to do maybe.
Yeah.
And I would love to hear from people, especially when there's stuff that's missing from them,
Yep.
or bits that we might have gotten wrong. Like this is, it's really useful to actually get this feedback, and I would really, really implore people to do that if possible, to reach out to me and let me know their thoughts and their experiences, whether it's useful, whether it's not useful, whether it misses the mark for them.
Yeah, and as you said, the slides will be available, which will include your contact email, so people can always get in touch if they need anything.
Yeah, absolutely. Please do. I'm sorry for running over time. I just
Not
got carried away.
It's a really interesting field, and we really appreciate you sharing all your insights, particularly out of the research. And hopefully, I would love to see it go national and get some of the information out of the NT in Queensland and Tasmania, some of those states that you weren't, and territories that you weren't able to
we've been having
look
some
at yet.
with people there as well. Look, I noticed that there's lots of things in the Q&A. Are you able to screenshot them or copy them for me? Just so
I can send them
respond to any particular individual. They can drop in their email address as well if they want me to answer a question directly, because I've run out of time.
That would be great. Awesome, thank you. So thank you everyone as well for joining us today. Apologies for going over time, but I'm sure if you found it just as interesting as I did, you probably don't mind. Thank you, Dr. Drysdale. We do really appreciate you coming along and sharing the insights from your research and from your research team. If you haven't had your question answered today, I will pass them along to Karen. However, do also feel free to reach out to her via her email address. And just to let you know that we'll be holding more webinars and putting more resources on Cracks in the Ice throughout the year. So please feel free to subscribe to our mailing list to receive future updates.
Great.
So thank you.
Look, thanks to Cracks in the Ice. What a fantastic program. I've been following you guys and it's really good. So
yeah, it's amazing to have you on. Yeah, thank you so much for sharing your time. And thanks everyone for joining us today. I hope you have a lovely rest of the day. Thank you.
Thanks everyone.
Bye.